We're going to call the meeting to order. This is a Medicaid informational hearing, and I want to thank everybody for having such an interest in this topic, and it's something that our state needs to have a conversation about. The purpose of this meeting is to learn about the pros and cons of Medicaid expansion. Is it good for Kansans? Does it benefit the health of our citizens? Today's committee consists of both the Senate Ways and Means Committee as well as the Public Health and Welfare Committee. I want to thank Chairman Billinger and Chairman Gossage for supporting me as we continue through the next hour and almost 30 minutes. That being said, we will get started with the proponents, followed by neutral, and then opponents. Both sides have been told about the time constraints. If any conferee abuses the time, I will cut you off so that we can get through all who has signed up. Afterwards, if we have time, the committee will have the opportunity to ask both sides questions. We will begin with the proponents, and we have first Christine Osterlin, State Medicaid Director. Welcome to the committee.
Good morning, Chairman McGinn and members of the two committees. Thank you for this opportunity to provide testimony on behalf of Medicaid expansion. I am here this morning representing both KDHE as well as the Division of Budget. And both Adam and I will be available for questions at the appropriate time. So as we start our discussion about Medicaid expansion, let's first do a little bit of groundwork of where Medicaid stands today. Currently, in the Medicaid program in Kansas, not only do you have to be extremely low income to qualify for Medicaid, as an adult, you must also fit into one of four categories. You must be low income and disabled according to the Social Security Administration. You must be low income and elderly, low income and pregnant, or low income and a parent or legal guardian of a minor child. When we talk about low income, it's easy just to use that term, but what does it mean? In Kansas today, for an adult to be eligible for Medicaid, they must be at 38% of the federal poverty level or below. What does that mean? A single parent with one child, the Medicaid threshold today is $648 a month is the maximum they can earn, or $7,776. If they make above that threshold, they do not qualify for Medicaid. So what does Medicaid expansion do? Medicaid expansion increases that limit from 38% of the federal poverty level up to 138%. It also removes those categorical requirements that I just outlined. So what does 138% of the federal poverty level look like? Again, going back to that single parent with one child, under Medicaid expansion, that parent could earn $2,351 or $28,212 to be eligible for Medicaid. I would submit that making $28,000 a year with a child is a pretty low income to sustain housing, transportation, and other expenses of daily living. So let's talk a little bit about who would Medicaid expansion serve. I'm going to highlight three populations. The first one is our wait list for our home and community-based services. Currently today, about 70% of our individuals on the wait list qualify for Medicaid under our current program. That means that they have access to behavioral health, therapies, and other supports, while not as extensive as the waiver, hopefully is enough to help sustain their health until they can get a waiver slot. The second group that I'd like to, going back to HCBS, if we expand Medicaid for that 30% that is currently not eligible, many of them would be eligible for Medicaid while they wait for a slot on the waiver. The second group I want to highlight is medically needy, or what is referred to as a spend down program. This is a program for individuals, our fellow Kansans, that have very catastrophic health needs, very expensive. It's in the tens of thousands that they're spending, sometimes monthly, to sustain their health condition. Medically needy allows them to spend down their income to $475 a month before they qualify for Medicaid. Many of those individuals under expansion would qualify for Medicaid and not have to spend their income down to $475 a month. The other group are just our individuals who do not reach that Social Security disability threshold, but have chronic conditions such as cancer, mental health issues, and the like. Again, because of that categorical requirement today, they don't qualify for Medicaid. Under Medicaid expansion, these individuals could have access to the healthcare services that they need. Over the last few years, there's been a lot of improvements to the Medicaid rates, and we thank the legislative body for doing that. And those increases do need to continue because we know the healthcare landscape is always changing. But one thing I want to point out as we look at rates, currently when we do a rate increase in Kansas, we know that Kansas has to pay 40% of that rate increase and the federal government chips in 60%. If we expanded Medicaid, we would have an entire segment of the population where we could get a 90% match. And essentially what that means is the overall state investment in rate increases would decrease if we had Medicaid expansion in Kansas. The other thing I want to highlight around Medicaid expansion is some of the new incentives that have been provided by the federal government. For the 10 states that have chosen not to expand Medicaid at this point, the federal government has added a sweetener that would be a 5% FMAP increase for our existing population. That equates to about $500 million that Kansas would receive over the next 2 years. And what does that mean when we talk about Medicaid expansion? It means Medicaid expansion expenses would be covered for the next 8 years in the state of Kansas. Another item that I'd like to highlight is there's been a lot of attention given to the SGF and the federal participation match, but there's another benefit of Medicaid expansion. In the governor's budget, you did see that there was the savings of about $61 million in fiscal year 25 and $121 million in fiscal year 26 for state general revenue. But there's another positive impact. If we would expand Medicaid, providers across the state would receive about $675 million in all funds payments in fiscal year 25 and about $1.4 billion in all payments in fiscal year 26. And I did include a table in our joint testimony that you can refer to that outlines these figures. So essentially, Medicaid expansion provides a benefit not only to the state general revenue fund, but to our providers across the state. On the contrary, right now, the state is looking at paying about $150 million more in SGF to provide provider rate increases. So again, Medicaid expansion makes good fiscal sense for the state of Kansas. Another thing I would like to point out for those that have limited access to healthcare services, typically they are going to receive what we call episodic care. They're not seeing routine physicians and providers to treat conditions, so they're receiving costly care. They're going to emergency rooms, urgent care clinics, and other places because they don't have access to healthcare like those of us that have health insurance. If we expand Medicaid and more people have access to healthcare services, we can drive our recipients to receive that care at the PCP level and the more appropriate levels of care. And then if they do need to go to the hospital for a catastrophic condition or an inpatient stay, instead of that being uncompensated care for the facility, that care is now reimbursed through the Medicaid program. And finally, I would just like to say that studies have shown, and one thing I will point out as we talk about Medicaid expansion, while was passed in 2012, the early adopter states were 2014 and 2015. So a lot of the data is just starting to come in on the real impact of the Medicaid expansion initiative. We are starting to see that more members in expansion states are receiving access to preventative care, and that children when their parents are enrolled, are more likely to get their well child visits and immunizations. And with that, I can see my time is up. I will close, and Secretary Prophet and myself will be ready to answer questions at the appropriate time.
All right. Thank you,
Thank you.
Christine. I did give you a few extra minutes since you are the Medicaid director.
I appreciate that.
Next, we have Eddie Herman, CEO, Hayes Medical Center. Welcome.
Thank you. Thank you, Madam Chair. Thank you for allowing me to address the Committee on Medicaid Expansion. Specifically, I'm here to bring a highlight of the impact on rural hospitals. So at Hayes Medical Center, we are a sole community PPS facility. We also have a critical access hospital in Larned, Kansas, which is in Pawnee County. And we know that currently for us, the impact annually on uncompensated care is over $14 million between that and charity care. We know this is not only a burden on us, we know it's a burden on a sector of patients who would otherwise have access in Medicaid expansion to not have that financial burden put on them for the long run, as well as the facility. With Medicaid expansion, we would see about a $1.3 million of uncompensated care go away for us as a facility, as well as we have FQHC that's in town in Hayes, which would be another additional $900,000 of uncompensated care impact for the FQHC on the funding on that point. So we also know that many of these patients have employment, and they just don't meet the threshold to make enough money, or they don't qualify for any of the stipends that you might get to be able to go out to the market to purchase insurance. They fall into that gap. As we look at rural hospitals, we understand we are the backbone of most of these communities. Most of the time, we are the largest employer in that rural community. And really, without us and the schools there, it's really a death sentence for many of those smaller communities. And so as we look at this, we've also put a large tax burden on these small rural communities. They average over $700,000 a year in subsidy to the local community hospital that they have just to keep it open so that they have access. Some of them are in excess of $1 billion annually. So with Medicaid expansion, you're actually giving them the opportunity to lower their tax threshold in their local community, and or take a choice at that point and maybe reinvest in your recruitment for providers, because it is much more difficult to recruit physicians to a rural community than it is to any type of metropolitan community. And I know that for us, as the only level 3 trauma center in Western Kansas, that we have to make determinations on what service lines do we continue to carry forward. And without us being there, there are many service lines right now where people in Western Kansas will have to drive over 3.5 hours to receive care, especially as it's related to heart surgery, nephrology, and many of those other specialties where we're the only provider of that service currently. And we know that this Medicaid expansion is really here to support rural Kansans, our farmers, oil field workers, and those who actually just love the rural way of life. And we look at other states that touch us currently. They've expanded Medicaid and brought care to a group of citizens who we know desperately need help. In many of those states, they show that the people who are on Medicaid do eventually bridge over because they can be afforded the ability to stay in a role long enough to either receive enough raises and or move into a full-time position that would then allow them to transition into either the market because they qualify for some of the subsidies to help them do that, and or they get into a position where it's just provided by the company itself.
Mr. Herman, we need you to start wrapping it up, please. I need you to start wrapping it up, please.
Okay. Yes, ma'am. So let me just finish up then to say this also would be very beneficial as we see professionals and physicians crossing state lines. We already know where Medicaid expansion exists. So, Madam Chairman, thank you so much for your time.
Thank you for your testimony. Marceline Dover, private citizen. Welcome to the committee. Can somebody?
I got it. No, I'm good. You don't need to
You're
lower it.
okay.
Hi, my name is Marceline Dover. I appreciate you guys opening up the time for people to come and speak. And I appreciate you guys listening to our stories. So I came today to share my story of being affected of living in the Medicaid gap when I was in college and being diagnosed with multiple sclerosis and having to find a way to pay for healthcare. And not just my own story. My mom, when I was in college, was diagnosed with cancer. She had waited until she turned 65 and got on the state's Medicare program before she had been diagnosed. And she was diagnosed at stage 4 and very shortly after went into hospice and passed away. And I was misdiagnosed for 2 years before I got my diagnosis of multiple sclerosis. And partly because I was unable to have or afford health insurance when I was in college. And so being misdiagnosed with MS for 2 years, if you know about multiple sclerosis, it is a progressive disease with permanent disability that accrues. And having no ability to get diagnosis or get treatment meant having more physical disability that is permanent, that cannot be treated and there is no cure for. And there are people all over Kansas who fall in the Medicaid gap, and delaying care for these people is life altering. And the quality of life that people expect to have, you know, growing up in Kansas, I always thought, you know, you do things right, you work hard, and you can make your way in life. And wasn't expecting something like a health care situation to throw that all off the rails. But I come before you having received some donated care through my community. And I find that it is your guys' duty as much as it is our duty to care for other people here in Kansas. And expanding Medicaid would impact over 150,000 Kansans like me who fell in the Medicaid gap and who are not receiving care and who desperately need that care to sustain a quality of life such that they can achieve their goals and succeed in Kansas. And that is all I have to say today. I would be willing to answer any questions you guys have at the end. Thank you so much.
Thank you, Marceline. Thank you for coming today as well. Billy Hall, President of the Sunflower Foundation. Welcome to the committee.
Thank you, Chair McGinn and the committee members. It's a pleasure to be here today. I am Billy Hall. I'm the CEO. I'm the president and CEO of the Sunflower Foundation. It's a statewide health philanthropy. We work across all communities in all Kansas and counties in Kansas. Our mission is to serve as a catalyst to improve the health of Kansans. I'll be brief with my comments today. It relates to a poll that the Sunflower commissioned. We wanted to understand the views of small business leaders regarding expansion. It was simply, we had not, to my knowledge, we did not have information on where they stood on this. We were interested in the economic impact of Medicaid expansion, especially for small businesses and the communities they serve. They are the lifeblood of their communities. Small businesses have not played a prominent role in previous polling efforts, and we were very curious about what their thoughts and opinions were. And to be really honest, we did not have any idea where they stood on it. So we just took a risk. The poll was designed and conducted by Neil Newhouse of Public Opinion Strategies. Public Opinion Strategies has a solid history of polling in Kansas, and Neil Newhouse is a credible pollster with 40 years of experience. In our opinion, and if you have your testimony in front of you, you'll see the infographic that we had as well. In our opinion, the most significant finding of the poll was that 83% of small business owners favored expanding Medicaid. That was before hearing of any other. In a poll, they often have several dimensions, and that was before they had any other feedback about what it might do for Kansas. With the sample size, we sometimes have had some questions. While the sample size may seem small, with 107 interviews that range a wide, they range the sectors of industries, at all kinds of industries and size and location. We asked the pollster about that size of businesses and that number that were in the poll. We got an answer from Neil. He said, given the overwhelming support for Medicaid expansion among small business owners, the margin of error would be 73% at its lowest and potentially as high as 93%. So I wanted you to know that because our first question to him was 107 enough? And so I trust him, and that was his answer. While the primary focus was the small business leader, the poll also surveyed over 1,000 Kansas voters to better understand their views. Without knowing much about Medicaid expansion in the first go-around of questions, it was 68%. After they understood a little bit more of the value and input and the opportunities to strengthen healthcare systems, it went up to 78%. Since releasing the poll, we have been surprised by the many conversations we've had with business leaders, small and large. I've been talking to them all across the state. We noted a few leaders from agriculture and oil and gas, and I hope you take time to read their quotes. That's what they said, not information. We did not give them a quote. That's what they said. Business leaders who reside in smaller communities worry about the viability of their local healthcare system and what that means for their ability to recruit and retain workers. As I mentioned, the two prominent business leaders representing agriculture and industry are very concerned of the viability of their own communities. They understand the importance of a healthy workforce. Small businesses are also important suppliers for larger businesses, and those issues have surfaced. So we're talking now to large as well as small businesses. We didn't have enough time to bring more quotes, but I can tell you right now, we've kind of hit something and it's coming around. We're getting a lot of reaction to this. As we go forward, I believe more voices from small and large businesses will speak out on the issue. A healthy workforce is essential to the state's economy.
All right, thank you, Billy.
Thank you.
Next, we have Representative Donnie Lambeth, North Carolina General Assembly via WebEx. Are you there?
Yes, ma'am.
All right, welcome to the committee.
Well, thank you for allowing us a few minutes to share our experiences here in North Carolina. And I have my good friend Jim Bergen from the Senate, and we're going to tag team with you guys out there. We are honored to be part of those who are advocating for Medicaid expansion, as we recently did in North Carolina. I am going to touch on a few very high-level key points as to the benefits of expansion. North Carolina has debated expansion for almost a decade. Numerous bills to expand Medicaid have been filed over this period of time, but none even had a hearing. As our General Assembly debated the issues informally, members talked about items within the bill that some members supported, while others found problematic. As a result of some give and take, each new bill introduced made changes that addressed members' concerns, building on the components members supported and adjusting those that were of some concern. Several major issues during these discussions included: can a work requirement be included? If not, is there an alternative? How will our state's share of expansion be funded? And how can we implement expansion without fixing our traditional Medicaid, which is in need of major reform at that time? And then what are the political implications? Key factors over our journey. COVID hit us, as it did in all our states. Funding increased, and we added significant new beneficiaries during this period. In 2021, North Carolina implemented a major overhaul of its traditional Medicaid program with a major shift from a broken fee-for-service system to a managed care risk-based model. In 2021-22, leadership appointed a bipartisan joint task force to study Medicaid expansion. Those hearings occurred over approximately 1 year and included testimonies from other states that had implemented expansion, including Ohio and Indiana, and had several years of experience that they could share with us. During these hearings, we heard the positives and the negatives regarding expansion in their state. For example, the HHS Secretary under Governor Mike Pence in Indiana shared data on their key outcomes and measurements that were significantly improved as a result of access and better care. That committee report is available if you're interested in having more detail shared with you. As the General Assembly convened in 2023, Expansion Bill 76, which also is available to you if you're interested, was filed and received hearings in both the House and the Senate, and was passed and signed by the North Carolina governor in March of 2023. Key aspects of the final bill included a focus around wellness, a jobs training program that provided incentives to participants who would like to return to school and better their education in order to get a better job. It's funded, the 10% of the state share was actually funded by our primary care organizations, our managed care organizations, and our providers. No state funds were used to pay for expansion. In addition, another key factor was the bonus money from the feds as a sign-on incentive for North Carolina. Approximately 80% of the individuals who are expected to sign up and are actually working. Many who have had no health care options for many years except the very expensive emergency room. North Carolina went live on December 1, and we are now close to 400,000 citizens enrolled, as we expect about 600,000 in the final count, which would be about 60% of our uninsured population estimate in North Carolina. We are utilizing the approximate 1.6 billion signing bonus to reform our mental health system as a major significant way to meet the needs of our citizens in North Carolina.
Excuse me, Representative Lander, you're going to need to wrap it up so we can get through all our conferees.
And I'm going to let Senator Bergen talk a little bit about mental health.
Just a few minutes, please.
I'll be very quick. And this is Joe Bergen. I do want to say hi to Senator Gossage. She and I served together on a couple of different things, have been at some meetings together, and it's always good to see her. We took $835 million of our bonus money and allocated it toward mental health. And I just want to tell you what's happened since December 1st. We have added about 394,000 people, but we filled over 500,000 prescriptions, and most of those have been for asthma and seizures. And both of those things are terribly important to deal with, so you keep people out of the hospitals. So we've really seen a big a move toward people getting health, people staying out of the hospital, and I'll wind it up and just say we'll be available for any questions later on.
All right, thank you. And thank you for joining us today.
Thank
Next,
you.
we have Sheriff Jeffrey Easter, Kansas Sheriff's Association. Welcome, Sheriff Easter.
Good morning, Chairwoman again, and committee. I appreciate allowing us to speak today. I represent the Kansas Sheriff's Association. My name is Jeff Easter, and I'm the legislative chair. I'll keep this very brief. The only point that we're weighing in on is we believe Medicaid expansion in the jails would be a huge plus. We have a very sick population that comes into our jailing system. In the last 12 years that I've been sheriff, our medical budget was $4 million. We're over $9 million now, and we go over it every year. There is very sick people that come into our custody. We're charged with making sure they receive really good health care. I'll leave you with an example. We had an individual over 2 years, had been over $1 million worth of medical care that is paid for out of county taxpayer dollars only. Because we receive a Medicaid rate, if they're in the hospital for longer than 24 hours, our cost was around $260,000. If we would have Medicaid expansion, the cost to our taxpayers would be much, much less or nothing. Now, you equate that to some of our smaller counties, they'd go bankrupt if they had a prisoner like that. Somebody that's not going to get out of jail because they are charged with the crime of murder. And so from a standpoint of the Sheriff's Association, that's the only point we're weighing in on, is that we would like to see the Medicaid expansion in the jails to save our local tax dollars so that those dollars can be better spent in other areas of county government. And with that, I will stand for questions. Thank you.
Thank you, Sheriff Easter. Next, we have Erica Christie, Deputy Director of Three Rivers Independent Living. Welcome to the committee.
Good morning. And good morning to the committee, and thank you for having me here today. And I want to definitely say good morning to Senator O'Shea, who covers a portion of our service area. So good morning, ma'am. So people before me talked about gaps and about the Medicaid gaps, and that was one of the focuses that we had initially when we started preparing testimony, is we need help filling the gaps. In the disability community, we meet people in different stages of their disability and different parts of their journey. So many times those people are working part-time and desire a more meaningful employment, but are dealing with some sort of situation. They don't earn enough to afford health care, but they make too much to qualify for Medicaid. So we find them in that gap triangle of, I can't quit my job, I can't go to the doctor, and I don't qualify for Medicaid. So those are the people that I feel like are falling in this gap and that we work with on a daily basis. And many people we work with do not have a disability determination, but have an underlying health condition preventing them from full-time employment. It can take years to qualify for disability, and also treatable conditions don't qualify for a disability. So we want to address those treatable conditions early and let people move on with their lives. So we have two goals as part of our request for expanding Medicaid. And one goal is a healthier direct service worker workforce. People with disabilities gravitate to this type of work because the shifts can be flexible, and they are passionate about helping other people with disabilities be independent. And our second goal is to get our consumers with who come to us with an employment goal request, and we're working on employment with them, to find full-time employment and address those health conditions and those underlying conditions that they're dealing with. So I am an example of someone who would not be standing here talking with you today if I did not have health care that addressed an adult onset disease that I experienced. And then I got quick treatment, I got therapy, now it's in remission. I'm not having any more issues. If I was a person in the gap that I just described, I would not be standing at this podium today. So I thank you for your time, and just expand Medicaid. Thank you.
Thank you, Erica, for being here today. Dr. Doug Gruenbacher, Kansas Academy of Family Physicians. Welcome to the committee.
Thank you, Chair and members of the committee. Thank you for the opportunity to submit testimony in support of Medicaid expansion. The Kansas Academy of Family Physicians represents nearly 2,000 family physicians, resident physicians, and student medical students across our state. And providing quality health care and quality health outcomes for our patients guide our public policy work. So family physicians are the largest primary care specialty in Kansas. We take care of our patients in our urban areas, our rural areas, everywhere. They are not only our patients, but they're also our friends. We take care of them constantly throughout multiple ways. We take an oath when we graduate medical student, which reminds us of our obligation to care for everyone, not just those with insurance. My partners and I provide full scope primary care in Quinter at Gove County Medical Center on the way west part of Kansas. So mile marker 107, guys. So if you ever come through, Rick knows where it's at. So, and for 21 years, I've seen patients who have delayed their care due to the inability to pay. They've received their primary care in the emergency room due to their inability to pay. They've gone bankrupt due to their inability to pay. They've stopped medications or care due to their underinsurance or with a high deductible. And lastly, I've seen patients, they've worked multiple jobs, part-time jobs, trying to make ends meet, but they just can't be eligible for insurance and they can't get as an employee benefit. So 2 years ago, just a few stories. 2 years ago, I had a patient who came to the office and I was really worried about having colon cancer. They needed a colonoscopy, but due to their situation and lack of insurance, they could not afford it. And I talked and worked with them and eventually was able to get them to come in for that colonoscopy. I took off this large precancerous polyp, and honestly, he was lucky, truly lucky, because if he would have waited any more time, it would have definitely turned into cancer. And with his financial situation, it would have definitely bankrupted him, requiring all the treatments. So that's just one story. Just a few months ago, I was taking care of a young adult, and because this is not just about working class adults, this is about kids too. I seen them. I was worried about appendicitis, other issues with abdominal pain, and unfortunately, because of again payment issues, they refused imaging and testing, and eventually just could not get them to do that because of cost concerns. Luckily, he recovered, but that's not always the case. Sometimes this ends up being a critical situation, and that ends up being a really poor outcome. So lastly, the emergency room in Quinter, I staff it. And if people don't have ability to pay or insurance or other issues, they go to the emergency room. And so that's where we take care of our most vulnerable patients. Laws require emergency care, regardless of pay. And who pays for that care? Right? And so when the emergent heart attack turns into a chronic medical condition requiring multiple medications and doctor visits, who pays for that care? And most of the time, uninsured patients will stop their medications or treatments due to cost concerns. The inability to afford medications and treatments create more costs for society. We have a choice. We can pay for prevention or we can pay for emergencies. As a Kansas family physician, I am saddened by what my hardworking uninsured patients experience every day. The truth is that these episodes are more commonplace than people realize because hardworking, low-income Kansans cannot afford adequate health insurance because they live in Kansas. The working poor find themselves in a coverage gap imposed by some of the strictest Medicaid requirements. As Kansas is one of the last states to expand Medicaid, I've also spoken to many of my colleagues in other states. And Medicaid expansion for them has been a game changer in their ability to focus on prevention rather than emergency care. Furthermore, in Kansas, 68% of rural hospitals, including my own hospital in Quinter, are at risk of closing, more than any other state of our size. If hospitals close and physicians leave a community, what will our farmers and workers do when there is an emergency or accident? What if an employee is injured in the oil fields? Where do our young families deliver their babies? If rural hospitals can't keep their doors open, these patients will drive further and further and further to find quality health care. Expanding Medicaid isn't about giving free services to the unemployed. It's about providing quality health care that will extend the life of patients currently working in the workforce, but caught in a coverage gap.
Dr. Gruenbacher, I need you to wrap it up, please.
I got it. It's about supporting our rural hospitals and keeping physicians in Kansas. And by approving a business model that isn't depleted by uncompensated care, that will help. This is not a political or ideological position or decision. This is a common sense decision. We urge you to expand Medicaid for our patients and communities in Kansas. I appreciate your time. We thank you for your time.
Thank you for being here and thank you for your testimony. At this time, we will turn to the neutral, which is Carrie Bruffett, President and CEO of the Kansas Health Institute. Welcome, Carrie.
Good morning. All right, I'm going to put my stopwatch on so you don't have to.
I got one running.
Oh, okay. Well, keep me honest. Yes, good morning. I'm Carrie Bruffett. I'm the President and CEO of the Kansas Health Institute. We're a nonprofit, nonpartisan health research and education organization right across the street. Seen many of you over at our events. We are neutral on legislation, but we aren't neutral on the idea of using evidence and information to make the best policy decisions. So we really appreciate the opportunity to present some of our work related to Medicaid expansion. There are a number of documents in your in the packet. I won't have time to go over all of those, but they're also linked in the electronic versions. So I am going to concentrate just really on the numbers and our updated estimates this year, focusing a little bit on what is new or maybe newish in those estimates from previous years. KHI has been doing estimates for Medicaid expansion since 2012, so it's been a while, but that model has evolved as proposals have evolved and the policy landscape has evolved as well. Really what's new this year when we're looking at expansion is the proposal in the Senate bill, and I know we're not talking about the specific legislation, but the proposal to include work requirements. So we took a little closer look at some of the characteristics of the Medicaid expansion population. We also, and this is not the first time, this is the second time we have looked at the impact of the federal incentives. You've heard other companies describe that in the American Rescue Plan Act, the approximately estimated $500 million. North Carolina also referred to how they've invested those funds. And then the hospital surcharge. I don't think that's been mentioned as well. That's also been something that's discussed. So very briefly, our estimates and KHI's estimates include the indirect effect of Medicaid expansion on children's enrollment as well. Our combined estimate is about 152,000 Kansans would newly enroll in Medicaid if expanded. About 106,000 of those would be adults, 66,000 of whom are currently uninsured. And that's also includes about 13,000 people who lost coverage after the end of the continuous coverage period. So their income, they were eligible at some point, became eligible for Medicaid during COVID-19, remained eligible in the unwinding because of income dropped off. So about 13,000 of that number would be eligible. It also includes a small number, about 2,000 folks who may be already eligible but have not enrolled, and adults, and 38,000 currently insured adults, many of whom may be receive insurance currently through the federally facilitated marketplace because folks between 100 and 138% of the poverty level who would be eligible for Medicaid if expanded are eligible for subsidies for the marketplace. Those under 100% of the federal poverty level are not. We also include an indirect effect on the number of children. About 45,000 children we estimate would newly enroll. We also see some impact of the unwinding in that number, so that's a little higher than some of the other years, but states that have expanded Medicaid have absolutely seen that children's eligibility goes up after their adult eligibility. Children's enrollment goes up after adult eligibility is adjusted. I will very quickly say our cost estimates, because I see I have about 40 seconds or so. Our cost estimates include the gross cost of Medicaid if expanded, and we look out for a 10-year period. That's a pretty ambitious period to try to project. We acknowledge that. We look at the overall costs, and absolutely Medicaid expansion does include costs, both for the federal government, largely for the federal government, and for the state. Our estimated net cost of the state totals $171 million over the 10-year period. If you didn't have the ARPA expansion, that would be more like $680 million. If you're looking at that figure in the issue brief. So, as you're thinking about how a state that would expand Medicaid could use the ARPA incentive, that $500 million, it could be, as Christine Osterlin mentioned, the equivalent of about 8 years of the cost of Medicaid expansion, or if it was invested in that some other way, that wouldn't cover that many years over the period. So we also include in your packet information about the number of enrollees or likely enrollees who are working. So nearly 7 in 10 are likely eligible adults who are working, and about 6 in 10 are working at least 20 hours a week. Then of those who are unemployed or not employed, about 38.5% of them have a child in the home. That's one of the proposed exemptions in the legislation. 19% have some form of in the census data, it's called a difficulty, but might be translated as a disability. 16% are students, currently students, mostly in post-secondary education. And about 3.8% of those likely eligible adults are veterans as well. So I have way more I could say, but I won't because I know I ran out of time. Thank you very much, and I'd be happy to stand for questions later.
And thank you for your testimony as well as the backup material as well.
Appreciate it. Thanks.
Appreciate it. All right, at this time, we are going to turn our attentions to the opponents. And first we have Senator Gossage. I'd say welcome to the committee, but you've already been here, so.
Thank you, Madam Chair. Some of you see me tooling around the Capitol in my little scooter because of my injury, but I just have about a week to go, hopefully, before I can eliminate that. Good morning, Chairwoman McGinn and my fellow members of this joint committee. It's an honor to be your vice chair and to share with you some of the consequences of Medicaid expansion that have been left out of articles, pamphlets, and other things that you may have received. Since I chair committees, I know that I really don't want conferees to come up and read their testimony. All of you have my testimony, so I'm just going to hit a few highlights. As a citizen legislature, most of us have real jobs. My real job for the last 20 years has been helping Kansans and people in about half the other states find affordable health coverage, including Medicare and helping them sign up for Medicaid. So I will focus on my area of expertise and what I have seen in not only states that have expanded Medicaid, but have not. So we'll talk about the non-group market. But I'm going to let others discuss Medicaid expansion's effect on states' budgets, the myth of expansion being the silver bullet for hospitals, the failure that numerous other states have seen with the expansion of Medicaid, including the promised job increase that ended with states losing jobs and experiencing hospital closures. So before we review what I've known, let me just talk about who is this eligible Medicaid expansion population. So we've heard others talk about 150,000. We've heard 70,000. Who are these folks? Well, we know that of that 150,000, 45,000 are children, and children are not included in the expansion population. We've also seen through KHI reports that about 68,000 of them are currently insured, either through an employer, a private plan, a short-term medical plan. So then who's left? Leaves about 38,000 Kansans. I'm going to talk about those that are currently insured and those who could be insured through the private marketplace, the federally facilitated marketplace. When this was passed about 10 years ago, it really hurt those in the middle age or the middle income bracket, but it was a boon for those who are low income. Let me explain what I mean. So 100 to 138% of the poverty level, we've heard those numbers. But let me just explain, that's $15,060 in the 100% of the poverty level. And 138% for individuals is $20,783. In my research, I've discovered that over 85% in the states that have expanded Medicaid, those populations are single adults. So when I help people every day in various states, on the second page of your testimony, you'll see that according to CMS, 171,000 Kansans chose a plan in the FFM, or the federal marketplace. And Kaiser Family Foundation stated, zero premium plans with enhanced subsidies are available for many low-income people, particularly in states that did not expand Medicaid. I see this every day. So over 50% of these receive premium subsidies plus the cost-sharing subsidies. Let's take, for example, someone named Bob. He's 27 years old. He's gone off his parents' plan at work. He's independent. He's earning the poverty level, for example. So he would have a monthly tax credit on healthcare.gov of $390 per month. I would be happy to sit down with any of my fellow committee members, show you healthcare.gov because I'm licensed and certified through there. We'll look up any zip code, any income and age that you would like to see. Well, this person, as you can see, would get a zero premium plan, no deductible. A doctor's visit would be $5. A specialist would be $10. urgent care would be 30, and emergency room would be covered at 20%. Outpatient for mental health is $5, and generic drugs are at no cost. The total out-of-pocket for the year could not exceed $1,550, to which these copays apply. This individual could, however, if they have lots of plans to pick from, choose the $7.68 plan. Notice it's the zero deductible, the $1,550 total out of pocket, but it does drop the primary care to $0, specialist to $5, urgent care to $15, caps emergency room to a total of $500, which could be paid over a period of time, no charge for mental health, and no charge for generic drugs. I see this every day. I help people find these plans and apply for these plans. But what happens if Bob we expanded Medicaid? Bob would receive a letter saying, thank you, congratulations, your state has expanded Medicaid and you are now eligible. Or you can keep the plan you have. I get a phone call from Bob. This is not the plan you wrote for me. My plan was like zero deductible, and this says, if you turn the page, this is what it says in my letter. $389 premium, $5,750 deductible, $8,900 out of pocket. Wait a minute, this is not my plan. Actually, Bob, this is your plan, because when a state expands Medicaid, the federal government removes all subsidies for any of the plans for people who are 100% to 180 and 138% of the poverty level. So I'm afraid your only option is, unless you want to pay full price, is this plan that you currently have, or since you're under 30, you can do the catastrophic plan below, which is $256. Both are going to be unaffordable for Bob. So of course, Bob goes on to Medicaid. In helping a family recently, mother called and said, can you help my two kids? They're going off the plan at work. They're both in college. My husband's employer they're going off there because we're going off of that plan. And so I said, happily, all I need is three things. I need the age, I need the zip code, and I need the income. Does she make around $15,000 or so? Yep, she does. She works summers and part-time. Okay, well, she's going to get an incredible plan through healthcare.gov. And we looked at the first plan you saw, the zero premium plan. Mom's like, great, can you get the same thing for my son? Sure. Age, zip code, income. Income the same, age was 2 years older, but the zip code she gave me was a Missouri zip code. So when I looked that up for Missouri, then you see the other graphic right there on that fourth page. And this is what it says if you live in a state that expands Medicaid. Your savings is none. You must look at full price plans who could be eligible for Medicaid. They get no subsidies whatsoever. So in conclusion, Madam Chair, wondering if anyone has thought to ask those folks that are currently receiving this, somewhere between 22,000 and 70,000, we don't have that exact number, who are eligible for these type of plans on healthcare.gov, who would be shoved off of their plans. So how does a Medicaid affect the current Medicaid beneficiaries? So the people that are currently on Medicaid have a hard time trying to find a doctor, a specialist. One young man that I had that was on its plan, like I mentioned, you moved to Colorado and said, can I get that same plan? You cannot. Colorado expanded Medicaid. Can you get me on Medicaid? Helped him sign up. Called a few weeks later. Can you get me off of this? There's not a doctor within 50 miles around here I have to take ADHD medication. And I have to go in every so often to have them renew and refill my medication. So I said, I'm sorry, there's no getting off of that. There's no other option for you. It's Medicaid or being uninsured. So we don't have to look at the promises of Medicaid committee. We can just look at other states that have already expanded in their experience. I urge my fellow legislators to vote against Medicaid expansion. Kansas is wise to prefer limited Medicaid funds for the truly vulnerable to whom Medicaid was originally designed. Instead, I would rather see our focus on removing obstacles that might discourage Kansans from seeking employment and barriers that might prevent employers from expanding businesses to hire workers. We should move more quickly to create and gain approval for our community-based waiver. I'm proud to have chaired the IDD committee to finally deliver long overdue services to those 5,000 folks who are on the IDD waiver list. Thank you, Madam Chair.
Thank you, Senator. Next, we have Sam Adolphson. Opportunity Solutions Project.
Thank you, Madam Chair, members of both committees. My name is Sammy Adolphson. I'm a visiting fellow at the Opportunity Solutions Project. I'm also the former Chief Operating Officer at the Maine Department of Health and Human Services, where I helped oversee the state's Medicaid program. I appreciate the chance to present today. We're in opposition to Medicaid expansion, but I want to present some information on why that is. And although I work for a think tank, I'm going to try to avoid the think tank wonk. And since I only have 4 minutes, I need to do that anyway. Here are just 10 quick facts that I think are really applicable to understand about Medicaid expansion. First of all, it's for able-bodied adults only. So sometimes in these discussions, folks conflate accidentally Medicare with Medicaid. This is not about Medicare. It's also not about expanding the Medicaid benefits that you already have in Kansas. The folks that are on Medicaid now, the disabled, elderly, children, poor families, they're not going to get any more benefits. It's not an expansion that way. It's only an expansion of eligibility to a new group in Kansas, and they are all able-bodied adults, many with no children in the household. The second thing is that enrollment and spending will blow past projections. We know this from every state that Medicaid expansion has happened in. And you've already heard some different numbers thrown around about what it will cost, how many people will enroll. We believe, based on looking at actual experience in other states, you'll see about 350,000 folks added on Medicaid. For context, your program now is about 450,000. So you're talking about almost doubling the size of the program. All due respect to the gentleman from North Carolina, they just started Medicaid expansion. They don't know yet what it's going to look like, but we do know early on, they mentioned it, they're almost 2/3 of the way to what they thought would ever be enrolled in just a few months. The budget would be similar. Arkansas thought it would cost $800 million a year. It now costs over $2 billion per year. Indiana was mentioned in a previous testimony. They just discovered in December a $1 billion shortfall in their Medicaid program that they hadn't projected. The third thing I want to mention is just on work. Medicaid expansion has a big negative impact on your workforce. And we know this by looking at other states. Kansas is a hardworking state. There's no question about that. And you all have seen a very small dip in labor force participation, about 3% over the last couple decades. If you compare that to Medicaid expansion states, most of those states are 10% or above in a reduction in labor force participation. And of course, you have about 86,000 open jobs in Kansas. So the last thing you need is more able-bodied adults kind of pulling out of the workforce. Fourth was just mentioned by the vice chair. Really important point is that we think the number is like 36,000 or so, but she mentioned between 20 and 70,000 folks who right now today have a private plan on the exchange with very little out of pocket. Those folks would be required by law to give up that plan and go on Medicaid should you expand. We also project that that would cost hospitals about $37 million in Kansas because, as you know, a private plan pays higher than Medicaid. Medicaid pays only about 78% of that plan. Fifth, Kansas is generous already. So you all have built this system that does support many folks in your state, and you've expanded the program. You've gone from 7% of your total budget to 23% of the state budget that goes towards Medicaid. And of course, that has an impact on other priorities for spending here in the state. Six, I mentioned this when I was here in January, you have a very high error rate in your program. It's in the upper 20s, almost 28%. I don't think it makes sense to look at expanding a program that has that kind of basic program integrity issue. And so that's something that you'll want to consider as well. Number 7, this comes up a lot. Obviously, we've heard from folks here from the hospitals already today. The bottom line is that in other states, expansion has not helped, especially rural hospitals. They're closing, hospitals are closing faster in Arkansas than they are here, and in other states that's true as well. You have a $75 million Medicaid shortfall already in your hospitals. I will say, or if you run the numbers, there are a couple hospitals that may help, and they're the big ones in the big cities. They are not the rural hospitals. Those hospitals stand to lose more under expansion. 8th, Medicaid expansion in other states is not making people healthier. I think other folks may talk about this a little bit, but I did a study that looked at drug overdose deaths, and they are in 14 out of 15 of the highest overdose states. Those are Medicaid expansion states. 9th, there's no deal coming out of Washington, D.C. There's no deal making to be had. You're not going to get a Kansas version of Medicaid expansion. The Biden administration will grant you no waivers, no cost control waivers, no work requirement waivers. You're going to get the same Medicaid expansion that California and New York has. And by the way, they both have tens of billions of dollars in Medicaid budget shortfall this year in those states. And then finally, I think this is just an important reminder is you all do have an impact on the federal deficit. There's no free money coming from Washington, D.C. There isn't a magical pot of Medicaid money. This is all deficit spending. We have a $34 trillion deficit. And the CBO and the Congressional Research Service have all said that if you don't spend Medicaid money, it just goes to reduce the bottom line on the deficit. So it isn't as if that money is flowing to some other state and you're missing out on it. So those are just kind of 10 quick reasons why we think that Medicaid expansion would be the wrong choice here in Kansas, and I appreciate the time.
All right, thank you, Mr. Adolphson. We're going to go back to Representative Will Carpenter.
Thank you, Madam Chair. Committee, apologize. We had final action, so I had to go back. I didn't want to miss a vote. But anyway, so interestingly enough, when I called the chairman and told her I was going to testify, she said, "Can you keep it under 4 minutes? I don't want to have to gavel you down." And so I will actually talk a little bit on, KDHE and KDADS and stuff like that. As I sat there and tried to, which I find awful difficult, was we don't testify very much. And it was kind of difficult putting together testimony. I now have a different respect for the people that testify before a committee, because normally I'm sitting up there. So anyway, it's a little more difficult, but I decided to go in and attack that maybe nobody else did. And I wasn't here when the other opponents were talking about. And by the way, I am an opponent of this, but I wanted to go about describing, and my concern is our most vulnerable people that we have now on our wait list. We have 5,279 people on our wait list right now for ID and DD service. We have 2,400 folks on the PD and wait list waiting for services. What's going to happen to those in this Medicaid deal? And if you look at my testimony, you can see I went down through there, and I won't beleaguer that project, or that subject. But what I will do is, here's just a few Medicaid numbers, just for a context. Current Medicaid population, Medicaid only, 387,000 folks in our state already covered by Medicaid. Total Medicaid folks cover the CanCare, or not only CanCare, but because that's CanCare medical, but also under our waivers and stuff like that, our totals are 456,000 people. We already insure 456,000 people in our state at a total cost of $5.4 billion, $2.2 billion SGF. KDADS, and that's only in KDHE. KDADS budget, $2.7 billion, $1 billion SGF. 27,982 folks covered by that. Go to our nursing homes. $862 million is what we spend on our nursing homes right now. $303 million worth of SGF. And that's 9,000 Medicaid folks in our nursing homes. So I just wanted to talk a little bit about those numbers. And my concern is, quite frankly, why would we want to take on another 150,000 folks on our Medicaid rolls when we still have these folks waiting for services already in our state? So with that, at the appropriate time, I will be happy to stand for questions, and thank you for having me.
Thank you, Representative Carpenter. Next, we have Michael Cannon from the Cato Institute. Welcome to the committee.
Thank you, Madam Chair. As I was putting my testimony together, I realized that the first time I came here to testify against Medicaid expansion was in 2013. I cite that in my written testimony, which I commend to you. There are pictures. And some of the arguments that I made back then, and they remain true today. The Medicaid program is rife with fraud. It increases the cost of private insurance. It crowds out private insurance and private long-term care insurance. It discourages enrollees from climbing the economic ladder. There's scant reliable evidence that Medicaid improves health. There's zero evidence that it is a cost-effective way of improving health. The history of government health programs instructs us that the cost of the Medicaid program, spending in the Medicaid expansion, would be higher than what the budget crunchers, the number crunchers were projecting at the time. And I encouraged Kansas and Medicaid expansion advocates to conduct the research that would be necessary to tell us whether and to what extent the Medicaid program or Medicaid expansion improves health. I also recommended reforms that Kansas could enact today, or then, and still could today, that would improve access to care for the most vulnerable Kansans and would not cost taxpayers a dime. These are reforms such as reforms to clinician licensing, giving health insurance purchasers more choices, reforming Kansas's medical malpractice liability rules, and other reforms. Since 2013, the cost of Medicaid expansion in states that have expanded the program has exceeded projections. Kansas has not, for the most part, enacted the licensing, health insurance, and medical malpractice liability reforms I suggested. Kansas has wisely chosen not to expand the Medicaid program, but Kansas has not done the research that would tell us whether Medicaid expansion would improve health. Now, it's easy to assume that compelling taxpayers to spend more money on health would improve health. But if that were true, the United States would lead all nations in all health measures. In my written testimony, you'll see data from the OECD that shows that the United States compels taxpayers to spend a larger share of income on health than any other advanced nation, by far. And the most reliable study that has ever been conducted on the Medicaid expansion, this is the Oregon Health Insurance Experiment, which looked at giving Medicaid coverage, measured the effects of giving Medicaid coverage to the most vulnerable people that we're talking about in the Medicaid expansion, people below not 138% of the federal poverty level, but below 100% of the federal poverty level. It found that program found that giving Medicaid to these people delivered no improvements in measured physical health outcomes, including outcomes that were the result of preventive care, amenable to preventive care. So the science is telling us we don't know what taxpayers are getting for the money they give to Medicaid, much less the money that they would give to the Medicaid expansion. And in the 11 years since I first recommended that Kansas collect those data, unfortunately, the state has not done so. Advocates of Medicaid expansion have not joined me in calling for the collection of those data. Instead, they've spent the past 11 years trying to game the Medicaid expansion and hide the costs, and they've been very successful at that. My testimony discusses, tries to expose what the actual cost would be. If they had joined me in that recommendation, they might have a stronger argument for expansion than they do today. Instead, the case for Medicaid expansion is weaker today than it was when I first testified in 2013, and I look forward to your questions.
All right, thank you, and thank you for being here. Brittany Jones, the Kansas Family Voice. Welcome to the committee.
Thank you. Chairwoman and members of the Joint Committee, my name is Brittany Jones, and I'm the Director of Policy and Engagement for Kansas Family Voice. We represent thousands of Kansans who care deeply about moms and babies and are concerned about tax dollars being used to pay for abortions. I'm here today to highlight the grave consequences that will likely arise because of a 2019 Kansas Supreme Court ruling that if this body implements Medicaid expansion. I'm not here today to argue about whether the case was right or wrongly decided. I'm here to simply state what the case law is and to explain what's happened in other states that have similar cases or similar laws on the books when they have expanded Medicaid. The Kansas Supreme Court created a right to abortion in the Kansas Constitution in the Hodes and Nausers versus Schmidt decision. This case now requires that strict scrutiny, the highest level of judicial review, be used when a case might infringe on a right to an abortion. In these instances, the legislature does not get deference. It is presumed that anything that this body does is unconstitutional. In the Kansas court decision, the court cited 5 different state court rulings that required state funding for abortion through Medicaid. Further, according to the abortion industry's own research arm, 17 states cover abortion through Medicaid programs. In 9 of these states, this was a mandate from a court, much like our court's rulings. Many of these are the very same cases that our court relied on in the Hodes and Nausers decision. By relying on these cases in its decision, the court set the framework for eventually striking down any statutory requirements that state funding not go to abortion. We have already seen several of our life-saving laws in Kansas struck down because of this ruling. And I believe that our restrictions on abortion funding may very well be next. In this case, we will no longer be able to rely on statutory provisions to protect our state dollars from being used for abortion. We have seen this in other states. Some states have seen a double-digit increase in the percentages of abortions after they expanded Medicaid when they had a court case like ours. We just saw yesterday that a court in Nevada required that their Medicaid program pay for abortions after they expanded. Based on reporting from the abortion industry itself, we know that abortions reached around 20,000 abortions last year. We're waiting for the official numbers, but hopefully we'll have those soon. I don't think Kansans want to be paying for a large percentage of those abortions like we've seen in other states. No matter how you feel about abortion, being forced to pay for those abortions, it's not something that is good for the people of Kansas. So I urge you not to expand Medicaid. Thank you.
All right, thank you, Ms. Jones. Dean Clancy, Americans for Prosperity. Welcome to the committee.
Thank you, Madam Chairman and distinguished members of the committee. It's an honor and a pleasure. Like the gentleman from Cato, I too had the honor of speaking before a committee like this in this room 9 years ago. And the evidence does indeed confirm the wisdom of what Kansas has done, which is to refrain from expanding Medicaid. I work with Americans for Prosperity. We try to reignite the American dream. And we're not just against excessive taxes and bad government spending and borrowing. We also have a positive vision. We want a personal option in healthcare. That means every American has access to the health insurance that they need and that's tailored to their needs, and they have enough money in a tax-free health savings account that they can use to pay for things, for example, their insurance doesn't cover. Medicaid expansion goes in the wrong direction from a personal option. A number of the other opponents have made arguments that I would have done, but I do want to say a couple of things. My background, I worked in the White House Office of Management and Budget. I'm a fiscal and health policy analyst, have been doing it for decades. And a point that needs to be stressed is that Medicaid needs to be reformed. It is inferior health coverage, and I think it's a mistake to assume that just because you have a Medicaid card, or indeed any health insurance card, that means you get health care. As has been pointed out, sometimes you can't get a doctor. 36% of Kansas physicians don't take Medicaid patients. 25% of Medicaid patients nationally have to wait a month to get an appointment. Medicaid expansion doesn't fix that problem. We need to reform Medicaid and health care generally. if the state expands Medicaid, I think you'll find what many other states have found. The cost of the expansion will exceed significantly even the highest official estimate considered during debate. It's kind of weird how it happens, but there seems to be a chronic underestimate of the enrollment level, of the woodwork effect, of the number of people who are already covered by private insurance who sign up and then are expensive. And the woodwork folks, as you know, cost significantly more than the expansion folks. And that is an unanticipated cost, unestimated often in these state debates. You also cannot count on the federal revenue staying at 90%. The 90% match rate will come down. The House Republicans in Washington have already included in their budget plan reducing the expansion FMAP, the federal share, to the regular Medicaid rate, which in Kansas, I believe, is 38%. That means that this population will become much more expensive from the Kansas point of view, simply because of federal budget cutting. And this change, by the way, is low-hanging fruit for fiscal conservatives in Washington. If they are able to influence policy and fiscal retrenchment becomes fashionable again, this will be high on their list. Also, reducing the amount of money states can raise through provider taxes is also on their list. The emergency room use, by the way, tends to go up with Medicaid expansion. There seems to be an idea that we're going to divert people to doctor's offices, but because Medicaid is free for people when you go to the emergency room, yet the doctor's office often won't give you an appointment, more people end up in the emergency room. There's about a 10% increase in emergency room usage after expansion in the states that have expanded. The biggest problem, I think, is structural. For a state, it's all or nothing. You expand, you can't dial it, you can't put lipstick on the pig even. It's all or nothing. You take it, and then when the feds, as they inevitably will, stop paying their share as promised, you're going to have to disenroll people. And that will not necessarily be pleasant. There's a better way, a personal option approach in which everybody has access. This requires a lot of federal reform, admittedly. And Kansas, by the way, has done a wonderful job in many areas. You have good laws on Farm Bureau health plans, on direct primary care arrangements. You have no certificate of need laws, those protectionist laws that are so popular in other states. Kansas does a great job on health policy generally. Let's keep it that way by refraining from this misguided policy and instead pursuing what we at AFP call a personal option.
All right, thank you, Dean. Committee members, you have written testimony that I believe is uploaded to the Ways and Means site. So if anyone else wants to read 463 submitted written testimony, that would be proponents, and then the opponents 3. But anyway, plenty to read there. And we're going to go open to questions here in just 1 second. I have a request of staff. When Sheriff Easter talked about the Medicaid while in jail, seems like there was a policy decision that was made several years ago, and I don't need this information today, but would you please look up the history and supply it to all the committee members? And then finally, I want to make sure I thank Senate President Ty Masterson for allowing this informational hearing, and also the chair of Ways and Means, Senator Billinger, and the chair of Public Health, Senator Gossage. So at this time, I'll open up for questions. Senator Holscher.
Thank you so much. My questions are for the gentleman from North Carolina, if they're still on.
Do we have somebody from North Carolina still on WebEx?
We're still here. Yes, yes,
Okay,
ma'am.
we have a question. Proceed.
Great. Thank you so much. You know, you've heard all the information from the opponents about why we shouldn't expand. Can you just kind of give me your thoughts in that regard as to, I'm sure you heard some of that same information pertaining to North Carolina as far as why you shouldn't expand there. Can you give us your thoughts as far as those arguments and why you decide to go ahead and expand?
Yes, ma'am. There was really nothing new from the opponents that we heard here, and that's one reason it took us a number of years to work through the issues. We do believe that we have a better projection. You may recall that I had talked about a similar hearing process that we went through where we heard from expansion states, non-expansion states. And one of the things that we made sure was that we looked very hard at the estimates. The other part that was critical for us was no state funding. We worked with our provider community and they were willing to pay the state share. They're also willing to pay if that formula changes to our regular, they're willing to do that. And the reason they're willing to do that is they're the beneficiaries of it. New money coming into the provider community that historically was free care or bad debts written off. So those were two components that we felt like were important to North Carolina that we made sure we covered ourselves. Nothing new. We are still early in the process, but we do believe we're on target with our projections. And we do believe we protected the taxpayers in North Carolina such that they do not have to put in any, even if there was an overrun, they would not have to put in any additional taxpayer money.
Can I ask a follow-up, please? Oh, okay.
Senator Gosh.
Thank you, Madam Chair. I do have a question, and this would be for any of the opponents. Do we have a percentage of those that are not working that are in the expansion population in other states?
Madam Vice Chair, we do from across all the states that will provide data, and I believe that's about 70% of the states that have expanded. The number is 55% of Medicaid expansion enrollees do not work at all. That's zero reported income, no income. So of the remaining portion, there's a mix of, part-time type of work, but 55% do not work at all. Obviously, that's the average, so it's higher in some states and lower in others. And we have that data we can make available to the committee.
Thank you, Madam Chair.
Thank you.
All right, other questions? Senator Pittman.
Thank you, Madam Chair. This is a question for Brittany Jones. Ms. Jones, I don't know if you know this. Could you tell us what we currently have pregnant women covered by Medicaid. And do you happen to know the level of poverty that we cover them at?
Thank you. I was like, something wasn't right. Thank you. I don't know the specific percentage on that, but if you'll notice in my testimony, I nod to some of that, and we've talked about this before, that yes, pregnant women are generally covered by Medicaid currently. But what my written testimony clarifies is many of the women who they get on Medicaid because they are pregnant. But if they had an abortion, they would no longer be on Medicaid. And so it creates a funding stream when you expand.
Okay, so just to clarify that, Madam Chair, currently it's 178% poverty level. Pregnant women are covered by Medicaid.
That sounds right.
And the expansion typically goes up to about 138%. So there wouldn't be any new pregnant women covered by the Medicaid expansion is what I'm understanding.
That's not my understanding, and that's not what's happened in other states, but you're allowed to have your opinion.
Senator Petty.
Thank you, Madam Chair. This is a question for Christine. Christine.
Oh,
Christine. Sorry. I can share. I know that Christine goes into Dean, but Christine, it was mentioned in opponent testimony that our Medicaid program is full of fraud. And I was just wondering if you might be able to speak to that.
So the number that's reported was from a 2019. It's called a PERM audit. It's a payment error rate measurement audit. That was, for those of you that have been around for a while, that was in the height of the backlog. And the primary driver of those results was anytime you were untimely with processing an application, it's considered an error. There was a 2022 PERM audit, which our results went down to 6.9%. So I think to use the 2019 data is a little misleading.
Thank you. So 6.9% is what in
Yes.
2022.
And yes, and we are just in the process now of starting our next perm audit cycle.
I thank you for that current information.
Thank you.
Senator O'Shea.
Thank you, Madam Chair. My question's also for Christine, so if you just stay up there. Can someone who qualifies for Medicaid still buy a personal policy?
So in Medicaid today, we actually have what we call a premium assistance program. Right now, that program is limited to employer-sponsored insurance, and how that works is if you are employed and your employer offers a plan and you want to enroll in that, you can. What Medicaid does is they have what we call a cost effectiveness evaluation that's done, because what you want to be sure is that paying the premiums and all of that for the private insurance or the employer-sponsored insurance would not be more than what we would pay if they were fully Medicaid. But yes, we do have that option, and that is contained in the governor's bill as well to do a premium assistance program.
Senator Gossage.
I can address that for the senator, and that is, since we have not expanded Medicaid, even if you're on Medicaid, you would have to go off of Medicaid to be able to apply for a policy. But anyone can apply for a policy. It all has to do with your income as to whether you get the subsidies. So currently, if you make no money on healthcare.gov, you would have to pay full price. They do have a work requirement. So if you work at Wendy's for $12 an hour, you make $15,000 or $12 an hour, 25 hours a week, that's $15,060. You would get the policy that I mentioned. But if you expand Medicaid, that's no longer available.
Okay. All right. Thank you. One last question, Senator Pittman.
This question is for Eddie Herman, if he's still here. Mr. Herman, appreciated your testimony. I have a lot of concerns in my area about property taxes. It's one of the things that I'm very highly focused on and improving our lot there. Do you, from your perspective, in your area, would Medicaid expansion actually help with property taxes for our citizens?
Yeah, Medicaid expansion would absolutely help a lot of the rural areas have the option of whether or not they wanted to continue to tax. At that point, I think it's up to the community of, do you reinvest that money and keep the tax so that you can either improve infrastructure, and or do you go out and try to be more competitive on the recruitment front for your providers and your staff?
And could you just clarify for the committee why this improves property taxes for your community?
Well, because right now those people who come in are not paying anything at all. And so as those facilities, a lot of them that are county facilities, as they have that shortfall is taken up on the county, which is then covered by the people through the property tax. So they have a mill levy. And so, a good example would be Rooks County, just to the north of us, pays a mill rate of $725,000 a year to help sustain their facility up there.
Thank you. I said one last question. I didn't realize Senator Petty wished to be recognized. So Senator Petty.
So this is a question for Carrie. Carrie, it was mentioned by an opponent that Medicaid expansion would only cover able-bodied people. And so I'm wondering about how does that affect our population of our disabled population?
I think my impression of that testimony was he was talking about like categories, categorical eligibility. As the materials that we shared with you indicated, there are, again, about 19% of those who are not working who are in the likely eligible population for Medicaid who likely have some kind of disability. It may not be a disability that would qualify them currently for Medicaid. May not, as another conferee talked about, it takes a few years to go through the disability determination process. So there may be some individuals, we would anticipate there would be individuals who would be in the expansion population who would have some form of a disability.
So
does that get to your point?
So people with, so Medicaid expansion does not just deal with, I mean, there could be people that are disabled that are receiving Medicaid expansion. Isn't that true in other states?
Sure, absolutely. That would be true in other states as well. And some of the states that have seen some change and slight change, and it's not in every state, they haven't seen the same numbers, but some reduction in the applications for Social Security for SSI disability determination in states that expanded Medicaid because they're more likely to be eligible for the medical care that they would need.
Thank you.
All right. I want to thank all the conferees for doing a fine job on trying to stick with the limited amount of time we had. And I also want to thank those in the audience. You did a great job. And I know many of you had to stand for an hour and a half. But once again, go to kansaslegislature.org and go to the Ways and Means Committee, and you'll find all the information and testimony that was presented today as well, if you'd like to read more or see those documents. Seeing nothing to come before us, we are adjourned.